speaker to Dr. David Davis. Is a specialist in emergency medicine. And at our request, he was invited by Dr. Hirsch, whose absence we all feel and regret, but who has been helpful to us even before he left by arranging this lecture. This lecture responds to things that we are interested in. We are psychiatrists. We are not in the field of emergency medicine, and yet sometimes we are faced with emergency issues. We have many questions about how much do we have to do, how little do we have to do, how to do it safely. And it's a good opportunity right now to learn about how to best handle these situations. Dr. Davis is working in the emergency department at North Carolina Hospital and Easton. He has been board certified in emergency medicine for the last 6 years. He has also a law degree, so we may want to ask questions concerning liability and so on. I think he's very qualified to help us with that. And he also is interested in quality assurance. So it appears that Dr. Hirsch has really picked a very good speaker for us. So without any further ado, I'd like to introduce to you Dr. David Davis.
I have some handouts. I've known Dr. Hirsch a long time. He and I go back to when our children were quite little. I'm sorry to hear that he's leaving. I know that those in the psychiatric field have a wide range of experience in medical treatment. Some of you, I'm sure, feel comfortable with chest pain, heart disease, and others feel as if you know very little. Also in terms of overdoses and other metabolic emergencies. Dr. Sanford has told me how you do have a wide range of ages here and how some of them have underlying medical problems such as asthma, diabetes, seizure disorders, addiction problems, liver disease. Let me give a brief overview and try to cover a number of things lightly, and then we can try to focus in on what the concerns of various people might be. On the page you have called Emergency Events, I've listed a variety of things that I think you might run into that you would like to have some feeling of at least an ability to recognize what's going on and a list of things that you might think of. As you know, it helps very much to have a high index of suspicion. Some things, if you don't think about them, they'll slip right by you. Under cardiovascular, chest pain. What do you do when someone complains of chest pain? You need to call the paramedics. Can you sit and watch it for a little while? Can you try giving them an antacid? Or anti-inflammatory like Advil or aspirin for chest wall pain? I'll give you a few clues on that. I understand you do have paramedics that are close by. And certainly in someone who has risk factors and is complaining of a pressure pain, and they're nauseated and sweaty and short of breath and weak, there's no question about you're going to call paramedics right away. Risk factors play a very big factor in whether someone should be admitted and watched for chest pain. Family history, number one. Smoking, number two. Third, a history of high blood pressure or diabetes or high cholesterol, lipid abnormalities. Prior history of heart disease. Any of these risk factors in someone that's over 35 or 40 has a pressure pain, and any of the associated symptoms, nausea, sweating, weakness, short of breath, needs to go to the hospital. They need to go by an ambulance who can take care of complications if need be. I do understand you have some materials here, that there is a crash cart, call it that. But of course you're spread widely, and the crash cart might not be available. I'll get to the second page, materials and skills, but just let me mention that oxygen is number one for so many things that you're liable to run into. And that includes chest pain. It also includes seizures, overdoses, electrical shock, a lot of the things that we were down here. I don't know whether you do have oxygen immediately available in different buildings. It never hurts to put the oxygen on, even if it's, you may have heard how people with chronic obstructive pulmonary disease, emphysema, are sensitive to oxygen. Their only drive to breathe is from low oxygen, not from the high carbon dioxide like a healthy person. And they can quit breathing if you give them oxygen. I mention this because you may have fears that maybe you shouldn't put oxygen on everyone. But in the situation that's happening before the paramedics get here, go ahead and put it on. Don't feel afraid to put oxygen on anyone. Chest pain is also commonly caused by esophageal reflux, acid coming from your stomach up into your esophagus where it's not meant to be, where it's irritating, and it can cause a Charlie horse-like symptom in your esophagus, a spasm. You may remember the pain of a Charlie horse in your calf, the spasm. It's intense. You can get the same thing in the lower part of your esophagus. It can be intense pain, radiate down the arm to your jaw, make you sweaty, just like angina. You, of course, don't know this, so that's where the risk factors come in, the age, whether they've had this before. Certainly it isn't going to hurt to give an antacid. Give somebody 2 tablespoons of a liquid antacid and see if that helps, especially in someone who's 20, 25, 30. Cardiac arrhythmias, irregular pulse. All you have to do is identify this. So you need to know how to take a pulse. I'm sure I would expect everyone here to know how to do that in different places, either at the wrist or the neck. I'll touch again on the importance of observation. And that may be one of the most important things that you can do to help the paramedics and your patient. But you need to be able to take a pulse and recognize an irregular rhythm. A skipped beat, when it's going along regularly and then skips a beat, is actually a premature beat in most cases. The premature beat comes so early that the heart is not filled with blood and does not give a palpable pulse, and then there's a pause until the next regular. If people are having more than 5 or 6 of this a minute with chest pain, that's called paramedics. An irregular pulse, it's important to know. You want to know the rate. You don't have to count it for a whole minute, but count it for 10 seconds or 15 seconds and multiply by the appropriate factor. On the other hand, if it's very fast, it can be 160, 200, 180. These are the supraventricular tachycardias. Some of you may remember the maneuvers you can do to try and break those without Valsalva maneuver. Take a deep breath and hold against it as if you're blowing up a balloon or straining the toilet. It's the carotid massage. If you feel comfortable with that and they have a fast, regular rhythm, go ahead and try that. And certainly ask them to do the Valsalva. But mainly recognize the arrhythmias. The thing to remember is if it's too slow or too fast, it isn't going to pump well. You're not going to get enough blood to the head, and they'll have consciousness changes, weakness, and short breath. If it's too fast, it doesn't pump well because the heart doesn't have time to fill in between each beat. Pulmonary edema. The lungs suddenly fill up with fluid. It's a backup from the left side of the heart. You can increase pressure in the lungs, get a lot of fluid. these people invariably have high blood pressure. They tend to be clammy, and they'll be complaining of shortness of breath. And if you put a stethoscope to their lungs, you'll hear a harsh, noisy rouse, the crackling sound. It's not a fine crackle, it's a harsh, noisy one, and it'll be more toward the bases. This will usually be in people that have had prior heart disease. Someone, we talked again about, they're having chest pain or not, but if they're clammy, short of breath, you need to call paramedics. And they can treat this very effectively once they start on IV with Lasix and morphine, even before they get to the hospital. But they can come on very suddenly. You have blood pressure cuffs, sure, you're trained in taking a blood pressure. Someone trouble breathing and high blood pressure and clamming, that's pulmonary edema. You go to the hospital right away, and they need the oxygen. That's the one thing you can really do for them before the paramedics get here. Oxygen, make sure they're getting air in all right, they're not obstructed, and do your observations. Shock, low blood pressure, same thing. You can help with observation, with giving them oxygen, and here you can help with positioning. Get them on the floor, get their legs up, let the blood run back where it should. Vasovagal reactions can give you a shock-like picture with a slow pulse, a low blood pressure, a clamminess, a nausea. They can, of course, pass out, fall to the ground. A vasovagal reaction can happen from emotional stress, from pain, from nausea, from other causes. They all improve when you get them on the ground. Whenever someone looks like they're going to pass out, and they're complaining of lightheadedness, and they slump in the chair and you feel like you want to hold them up, don't do that. They're already not getting enough blood to their head. You want to increase the amount of blood, lay them down. Protect their head if you have to. Don't strain your own back trying to hold somebody else who's falling. Concentrate instead on holding onto their head and neck so they don't injure their head and neck. Let them slump on down to the ground. Best thing you can do for them. Then you want to do your observation. Take the pulse. It will be slow. 30, 40 a minute. They may be clammy and nauseated, but if it's a vasovagal reaction, they will improve within 10 seconds, 30 seconds when they're on the ground. They'll come to what happened. I couldn't hear anything. My tunnel, my vision dimmed. Tunnel. Pulmonary embolism, a blood clot from lower extremities or pelvis to your lung. The hallmark is low blood pressure, fast pulse, often pleuritic pain or pain of breathing, and it happens suddenly. You may not see things in the extremities. There again, you've got chest pain, shortness of breath, low blood pressure. Call the paramedics, put them on oxygen. If blood pressure is low, get them down, get their feet elevated. These are the main things you're liable to run into with chest pain and cardiovascular abnormalities. Pulmonary problems, airway obstruction, something that you can do a lot about, whether it's from someone who swallowed a piece of steak, someone who has vomited and sucked some vomitus back in, whether they've swallowed something that's gotten stuck. There are some infectious causes, microbitis. Some of it is factitious. Patients can give you an airway obstruction that seems extreme. But they'll be getting the air in and their color will be good. Airway obstruction going on. If someone is holding their throat like this and they've been eating, they've swallowed something and it's stuck until proven otherwise. And you should all know how to do the Heimlich maneuver. It's highly effective. People are still alert, they're turning blue and they're clutching their throat and they can't talk. They cannot talk. So if you say, hey, what's going on there? So, forgot I was being videotaped.
Looks good.
At least I didn't turn blue. Do the Heimlich maneuver. Do it 2 or 3 times. If it doesn't work standing up, put them on the ground and shove up. If that doesn't work, sweep your finger around the inside. It may be something so big and high that you can reach it. some of you who may feel comfortable with it, if none of this works, and they're not moving air, and they're getting unconscious, you can make a hole in their throat. All it takes is a penknife. You need to know the place, and I can tell you right where it is, where your Adam's apple is. Okay, the next cartilage down, there's a little notch in there. You can feel it on most of your throats. All right, and right under that, you can feel the cartilage. And when you talk, you can feel your voice. You hum a little bit, you can feel it. There's no blood vessels there. There's nothing there but skin and cartilage underneath it. And just take a penknife, or better yet, a scalpel blade, 15 blade, and just poke it right through there, and then take it out and put the handle in and turn it sideways. And you've got an airway that they can breathe through. Now, this may seem dramatic. It is dramatic. It's also life-saving. And if this person is turning blue and hasn't breathed for 2 minutes, 3 minutes, there's nothing else to do. Their brain is going to be gone in another minute or two. What have you got to lose? Liability. If you do this, and it doesn't work, and they're dead, and somebody's going to question you, you're not going to be liable for this. Okay? The fact that it's an emergency gives you a tremendous amount of latitude to try things that you're not skilled in, even if you've only read about it or heard about it through this lecture. If this person is going to be dead in a minute, you can try almost anything you want. You're not going to be liable. And if it works, and they start sucking in air, this is something you can forget for the rest of your life. You save somebody's life. And that can happen. You can get an airway obstruction. But think about that sometime. You'll hear about it again. Every now and then, might poke around here so you can recognize it. Asthma. You probably run into that a lot, particularly with the weather changes. Asthma, of course, is a term that many people use for any trouble breathing. Let me urge you to distinguish between wheezing and stridor, or the absence of either. Stridor is trouble getting air in. They can get it out. Wheezing is trouble getting air out. They can get it in. They may not make much noise. They might not be moving much air. Asthma medicines, adrenaline, Theodore, the inhalation things, help wheezing, trouble getting the air out. They don't help stridor. If they're having trouble getting air in, that's upper airway. That's something blocking up here. You need to get them upright. In case of swelling, you need to think about whether they might have swallowed something. Okay? Stridor is wheezing. Sometimes people will be complaining about trouble breathing, and they don't have either of those. They're moving the air fine. It's going in and out. They're having big chest excursions. Okay? They're saying, I can't get enough air. But their color's good. These people are hyperventilating. They can have chest pain. Very typically, it's on the left side. It's sharp. It can be over or under your left breast. It can go anywhere the heart pain does. But they typically tell you, I can't breathe, but they're hyperventilating. You treat them with reassurance. Try to get them to slow it down. These people are not having trouble with oxygen, they're having trouble with carbon dioxide. Your lungs not only take in oxygen, they get rid of carbon dioxide in your body all the time. They're blowing off too much. It lowers the pH, it raises the pH. It causes physical changes. This is not something in your head. It causes spasm of smooth muscle, has a lot of airways, blood vessels. It interferes with the transport of oxygen into tissues. There's plenty of oxygen in the blood, but it doesn't get into the tissues as well, including the brain. So they have mental changes. They're scared, they can't concentrate. The best thing you can do is get them to slow down their breathing, reassure them. You've heard of using a paper bag. Carbon dioxide going out, it's coming back in a higher concentration. So it tends to build it up. But your body's making CO2 all the time, and if they'll slow down and breathe less than usual, then it'll build back up. There also is chronic hyperventilation. If you all breathe fast for a minute and then go back to normal, you're still going to be low on carbon dioxide. You're going to feel a little edgy and tense. feel like maybe you can't get quite there. I would imagine that you all see a lot of hyperventilation. You see a lot of it in the ER, an awful lot. If we think of our job in the ER as to relieve pain and anxiety, imagine that treating hyperventilation is something you do a lot. The caveat is if you treat them and they still have a high pulse rate and they're still complaining, then they need to go to the hospital. It could be a pulmonary embolus, could be some other airway problem. If you can't get them to calm down and turn it around, take them to the hospital. On the other hand, most people who have had this have had it before. It's not necessarily related to stress, very particularly. In fact, they'll say, it just came out of the blue. You know, I was just sitting here watching TV or eating dinner, and all of a sudden I had trouble breathing. It's part of a panic reaction. People get to the point where they anticipate this. They know that it comes and they can't control it. So the minute there's a little lurch, it's off to the races. Adrenaline city. And away you go. Once they learn they can control it by breathing control, this does not tend to be a big problem. Most people in this room have probably had a mild or a moderate episode of this themselves. Commonly when you're trying to get to sleep, you just feel like you can't breathe quite right. Anyway, respiratory failure is going to happen in your COPD patients with emphysema and chronic bronchitis. They will change color. They'll have mental changes, lethargy or anxiety. They will have a respiratory abnormality. They'll have stridor or wheezing or both. Bronchitis, which is a swelling and increased secretions in the larger airways, gives you both stridor and wheezing. They're having trouble both ways. And it'll be equal or one side or the other. Take them on to the hospital. Don't worry about whether you need to decide if it's hyperventilation or not. Any breathing trouble, err on the side of symptom. On the other hand, if it's someone you know, they've had this before, and they're very typically young, smoke, and say, I just can't get enough air. Moving it well, you can try and calm them down. You don't have to call them right away. Remember though, they'll have dry skin, they'll have a good color. Their pulse is probably fast. Breathing certainly. Abdominal pain. What do you do when someone says they have abdominal pain? Appendicitis has a classic presentation where they lose their appetite, have a vague mid-abdominal pain that you can't localize. Then it localizes, usually down to the right lower quadrant, and they can point with one finger. If they're going like this with their abdominal pain, it's probably not appendicitis, at least not yet. Large bowel pain tends to go across your low abdomen, all the way across. Small bowel in the middle, pancreatitis, liver, stomach, gallbladder up high. If it's crampy pain in the mid-abdomen and they're having diarrhea, watery diarrhea, large amounts, not just little squirts. And you can treat them with fluids as long as they're not throwing up. Just replace the fluids, you don't necessarily have to take them in right away. Large bowel pain, cramps across the bottom, constipation, anxiety, irritable bowel syndrome. Okay, you don't necessarily have to call right away for these things. The hallmark of abdominal pain, when you need to bring them into the hospital, is when their abdomen is rigid, when you poke on it and it's hard, it doesn't give, and or if they have a fever that's more than 100, let's say, or if there's localized tenderness. A ruptured viscus, ulcer in your stomach that's ruptured right away, will have varying amounts of pain. Sometimes when it ruptures, the pain goes away for a while until the acid spreads throughout your abdominal cavity. They'll have a rigid abdomen. They could have pain in their shoulder. You need to know that shoulder pain that doesn't hurt to touch or to move can come from something under the diaphragm, referred pain. Other things that can rupture are ovarian cysts, gallbladders, and sinuses. These things tend to happen pretty suddenly. The hallmark again is rigidity, fever, excessive pain. Bowel obstruction from people who've had surgery before, or even with fecal impaction, could give you a bowel obstruction. These people are dystonia. okay, and they start throwing up. These are not generally so urgent that you can't see what's going on for a while. Nothing's going to happen real quick. When they get into the hospital, they're going to take X-ray. And even there, it's not that urgent. GI bleeding. Bright red blood from the rectum could very well be a hemorrhoid. Vomiting blood, on the other hand, take them to the hospital, even if it's only a little. The only difference would be that if they've been vomiting repeatedly, and then they get a little bit of bright red blood mixed in with vomitus, that's not so urgent. If they're getting better, and it was only the last time they threw up, they haven't thrown up for 3 hours, obviously getting better. You don't necessarily have to follow people genital urinary, ureteral stones. Sudden onset, one-sided pain. Can be in the abdomen, more likely along the flank, and it radiates into the groin. Testicles on men, groin on men. Very often nauseating. Nauseating, vomiting, sudden onset pain. Often they've had it before. It may or may not be gross blood here. You don't have to see it. Sudden onset, severe nauseating, vomiting pain. They'll let you know. You need to take them on in because the treatment is IV narcotics to reduce it. Bladder distension. People say they can't go. You'll feel the bladder. You'll feel like a grapefruit right above the pubic bone. And it will be very tender. And that again is nauseating. Anything that distends a hollow viscus tends to be a nauseating pain. Fecal impaction can do that. Of course, neurogenic causes. Ovaries and testicles, the main thing you need to know about is they can have a sudden pain, usually from a twisting. Men who complain about pain in their testicle need to go to the hospital. And if it's a twisted testicle, they need to get there soon because you've only got about 4 hours to untwist it before it dies. So there again, we talked about kidney stone can give you testicular pain. Same thing. A man with testicular pain, whether it's swollen or not, don't delay. Get him to the hospital. Torsion is more common in younger kids. It's pretty rare over 25. Women can rupture an ovarian cyst. They can twist the ovary there. You can have a thing called Mills-Schmerz, which is an ovarian pain. 2 weeks before your next period, a sudden pain on one side or the other. It's from the cyst breaking loose and causing some bleeding. This pain is not that severe usually, and it passes in a matter of hours. Headaches. What do you do about headaches? People have everything from simple headaches to migraines to bleeding inside their head to tumors. Things that are increasing pressure inside your head, like a tumor or an abscess or some bleeding, tend to give you a headache that's worse when you lay down. If they wake up with a headache and it gets better as the day goes on, that's ominous. If their blood pressure is high and their pulse is low, that's increased pressure, what they call the cross of death. So if you measure their blood pressure and pulse, their pulse is in the 60s and their blood pressure is 220 over 120. Something's going on up here. Get them on into the hospital. The hallmark of a subarachnoid hemorrhage, or bleeding from a little aneurysm, a little dilated blood vessel, is that it comes on sudden. It can make them pass out. Very typically, there's some straining. They're on the toilet, or they're coughing and vomiting, intercourse, things like this. It gives you a sudden pain in your head, worst headache they've ever had, makes your neck a little stiff, may change consciousness. But anybody that says, this is the worst headache I've ever had in my life, I've never had anything like it, and it came on suddenly, to the hospital with oxygen. Subarachnoid hemorrhage is still proven otherwise. Migraines, on the other hand, tend to have happened before. They're often nauseating. People can have a prodrome where they say, I have visual problems, sometimes even a stroke-like appearance with tingling in one arm or leg, numbness. That goes away and then they get the headache. What happens is the blood vessels are constricted to begin with for some reason. The brain has an autoregulatory mechanism that says, wait a minute, we're not going to stand for this reduced amount of blood. We're going to open things up wide. when they do, it opens up and it starts to dilate and throb. That's when they get the throbbing, nauseating headache. That's a classic migraine. There are atypical ones. But if they've had these before and they can tell you about it, and if you have some oral medication, ergotamine or other things that work, compazine, you don't necessarily have to rush them to the hospital. Muscle tension headaches tend to get worse as the day goes on. They tend to be in the occiput or bitemporal. They tend to be a little bit tender. There again, they've had them before. Give them a couple of aspirin. Have them lie down. Put some cool compresses on. See if they don't go away. If you don't have sudden onset, not the worst one they've ever had, and they're not nauseated, for muscle tension headache. Hypertensive states. What do you do when someone has a high blood pressure of 220 over 120? This, of course, is dangerous in terms of blowing out blood vessels in your head or causing a heart attack. You need to be able to take a blood pressure. Usually they're on medication already. What do you do if it's 180 over 110? Well, that's not so high. If you'd like to get it down, it's worth repeating it in 10 minutes after they've been laying down in a darkened room away from stress. Any systolic pressure over 200, any diastolic pressure over 120, take them on into the hospital, even if it's only one reading. Okay? Even if they've had a couple of beers and 8 cups of coffee and they're under a lot of stress. And it just shouldn't get that high unless there's something pathological. A mild amount of high blood pressure is not going to give you a headache. So if they're complaining of my blood pressure's up, I can tell it. That's not necessarily true. You need the blood pressure cuffs. Altered consciousness. You may run into this a lot. A myriad of causes: trauma, overdoses, metabolic problems, diabetic insulin reactions. People who are on diuretics can get low on sodium, can get altered consciousness. Hypoxia, not getting enough air, not getting enough oxygen. Hypercapnia, high CO2. The chronic bronchitis and emphysema patients get this. They get real sleepy. They don't want to do anything to sleep. Structural central nervous system lesions, we talked about bleeding, abscesses, tumors, things like this. Essentially, if you can't come up with a good reason, if they're sleepy or they've taken too many over-the-counter sleeping pills, minor things, altered consciousness, you ought to take them on into the hospital, put the oxygen on them until the paramedics get here. The best thing you can do here is try and look at the environment. Be a trained observer, which you all are. Look around and see, is there anything they might have taken? Could they have fallen? Hit their head? Did something happen there? Talk to people who are around. See what you can figure out. Do they take medication already? Have they just eaten? Or have they not eaten for 2 days? Some things like this. Seizures. I would imagine you have a lot of people here with seizures. Is that true? A lot of them are on medication. There again, if they're going to fall, protect their head. Make sure they're breathing. Make sure they're not blocked. I'll get to the airway control. Collect their medicines so the paramedics know what they're taking. Figure out whether they've eaten and protect them from trauma. If it's a short seizure, you don't really have to do a whole lot. They probably ought to go into the hospital unless they're having them frequently. Some people have one a day, even on medication. 2 a day. One every week. One every week, a simple seizure, you know the patient. You don't have to do anything other than let the physician know. A seizure, of course, it can be mimicked by a shaky chill. Someone who gets a sudden temperature and shakes all over and their eyes may roll up in their head. A vasovagal reaction that we talked about before, with slow pulse, clammy skin, low blood pressure can mimic a seizure. All right? But a true seizure is going to have a period of unconsciousness. They do not retain consciousness. If they can talk to you, it's not a seizure. And They're unconscious even after they quit shaking. And when they wake up, they're confused. There's going to be a period of confusion. It can be anywhere from 5 minutes to a couple of hours, but there will be a period of confusion. This postnatal state. Usually they throw up as well, or have some nausea. There may be incontinence. If someone bit in their tongue, you can be pretty sure it's a seizure. Sometimes that'll be a question for you. Did they have a shaking chill? Did they just faint and shake a little bit and eyes roll up? Remember the vasovagal spell, they can lose consciousness and shake a little bit, but when they're on the floor, they recover quickly. 10 seconds, 30 seconds, no more than a minute. If they recover completely in a minute, that was not an epileptic seizure. It was something else. Hysteria, vasovagal, something like that. The simple things in the vasovagals recover completely. They're alert, they can get up. Heat stroke. We're getting into that sort of time. Most heat strokes are what people call heat stroke is more like dehydration and a lot of sweating. They've been out in the sun, they've been sweating a lot, they get a little low on fluids. They're usually fairly alert. Their blood pressure is on the low side, they have a steady pulse. They need fluids. They need to get out of the sun, get where it's cool, and give them a lot of fluids. And you don't have to take them to the hospital. They could have abdominal cramps, nausea, but they'll be talked to. Heat stroke is when you've gone through this heat exhaustion already, and they've even gotten so dry that they don't have enough fluids to maintain the circulation very well. And the body overcompensates. The body says, we got to retain fluids now. And the blood pressure gets high. They have a bounding pulse. They're red hot, dry in the skin. And they have mental changes. And their temperature is hot. 104, 105. These people have to be cooled down immediately. You ought to have ice around in different places. You know, you can get them in a bathtub with ice. That's fine. You've got to cool them as soon as you can. In the hospital, we do things like ice cold enemas, nasal gas cooling blankets. It's, you've got to get them cooled down. The people with heat exhaustion may have a low-grade fever. You know, the people that run marathons at the end of it will often have a temperature of 105, just excess heat they build up. But they'll have an excuse. They've been out working. But they'll be sweating. And they'll be talking shaky. Most people don't run marathons, but you can get some people that get caught up in a softball game, running around. It could be pretty good exhaustion. But if they have mental changes, hot and dry skin, bounding pulse, got to cool them off right away. Actively cooling, as opposed to the heat exhaustion being a more passive thing, replacing fluids and getting them out of the heat. Poisoning can happen with a number of things. The treatment that you can do is also to make sure they're getting oxygen, breathe all right. Many of the poisons do depress your respirations. You might wind up doing artificial respiration on these patients. How many people here know basic CPR? Raise your hand. Great. All right. So everyone's trained. You all know how to do that. You know how to take pulses, you can tell if they're breathing. There again, be an observer. It's the best thing you can do. Note the times, look around the environment. Try not to let them aspirate if they vomit. Turn their head to the side. Electrical shocks can happen from any outlet, that sort of thing. These tend to be much worse than you would expect. If someone has had an electrical shock, if they just tell you they have, I think you ought to send them on to the ER, even if they seem fine. Take their pulse, because they've got an irregular heartbeat. Notice their mental status. But particularly what seems like a minor burn could be burned all the way up the artery, all the way up the arm. These things come on later. So if someone says they've had an electrical shock, check their vital signs, make note of it, but go on and call the ambulance or send them on into the hospital. Drowning, near drowning, basic CPR for the most part. These these people will empty their lungs by themselves. Help them by doing modified Heimlich maneuver. They'll get a lot of it out right away. You turn them on their side. Basically do your ABCs, your airway, breathing, circulation. It doesn't make much difference whether it's fresh or salt water. Either one can give you electrolyte abnormalities. But there again, it's a hypoxic or an obstructive sort of thing. So try and get the water out. If it is in cold water, these people aren't dead until they've been worked on for a couple of hours. Same thing with electrical shock. These are the two things where we will work on people for hours and hours because they can come around. Allergic reactions, everything from a minor local swelling to hives to the true anaphylactic reactions where your lungs fill up with fluid and your blood pressure drops and your airway gets obstructed. Many insects are stinging right now. There's a particular caterpillar on the underside of leaves that gives quite a nasty bite. It is painless to begin with, and they tell you about it later. Depending on where the bite is, on the back of your hand, on the back of your foot, top of your foot, under your eyelid, where there's very loose skin, you can get a tremendous swelling from one bite. The whole hand can be swollen. This is still just a local reaction, treated with cool compresses with Benadryl if it's itching. They don't need to go to the hospital. It's not infected. If it's infected, it's going to happen later. It's just not that big a break in the skin. So, and you'll see this a lot. You'll see it on the back of the hand or on the top of the foot or around the eyes. And there'll be a lot of swelling. People will be really worried. But I'm telling you, in those places, if you can see a central spot, you can identify as a bite, you don't have to take them to the hospital. Cool compress, elevate, Benadryl. Aspirin helps too. Aspirin or the non-steroidals, Advil, ibuprofen, will all help these. Hives, on the other hand, unless they've had it before and they're familiar with it, I take them on. We can help hives a lot. Half the time you don't know what it comes from. Most of the time it's from food. It can be, some people can eat crabs all for their whole life, and now all of a sudden crab they ate went through some sort of water somewhere and picked up something they don't agree with. Seafood, melons, berries, nuts. These are the main culprits. Strawberries are incredible for causing hives. You wouldn't believe how often that happens. Hives, if they're familiar with it, you can treat it with Benadryl. You can get mild hives, you can get severe hives. Of course, if they're severe, I'd send them in. But a lot of people can have only skin manifestations without any trouble breathing or swallowing. And that's really the difference on how urgent you need to treat it. If they're having trouble breathing, even if it's from anxiety, and they have hives all over, take them to the hospital. Anaphylactic reactions come on very quickly. They're very dramatic. You need to give them adrenaline. I hope you have adrenaline around. I imagine you do for the asthma patients as well. Usually it's in prepackaged. We tend to give 0.3 if we're not sure. Give it sub-Q. If you're really worried about it, stick it under their tongue. It'll get absorbed real fast that way. It's almost like giving an IV. Dystonic reactions. People who are on the major antipsychotics, composite, can get not only the tardive dyskinesias, also some of the muscular oculogyric crises. They have a spasm of their neck and their eyes go all around. Very dramatic looking things, but you can always treat things short term with Benadryl. Give them a shot of Benadryl. Give them 50 IM. Give them a pill if it's not too bad. But any of the medications that you know of that can cause these, short-term relief can be obtained very quickly with Benadryl. The hospital will give it IV and there's relief in 5 minutes. With a shot, they ought to get some relief in 15 minutes. Same thing. Easy to treat, scary when it happens. As soon as you know what it is, it won't be so scary. It's not like that. Okay. Let me run down materials real quick. Oxygen. Gotta have oxygen. Use it. So many things. Go ahead and put it on my nasal cannula, mask, however you have to. IV access. I wouldn't expect that would be that easy, and paramedics are 5 to 10 minutes away. It's going to take people who are unskilled that long to get it anyway. If you have it, dandy. Airways. You should have some airways, the little plastic things that are curved, that you can slip back to hold the tongue up. If you don't have them, you can do airway opening yourself. Remember from CPR class. I like the jaw thrust, where you put it behind and you bring it up. It just gets the back of the tongue off the throat in an unconscious or obtunded patient. You can't keep it off there themselves. Just put your hands back here and just lift it up. You can do it, by putting your thumb under the chin, pulling it up that way, too. You can always use a tongue blade to get the tongue out. But if you have one of these little airways, they're really nice to have, because once you slip that in there, you don't have to worry about it as a jaw thrust. You can be doing other things, observing. The Heimlich maneuver, a laryngoscope, and medial forceps, which are the little things with rubber on them, have a little curve in them, so you can see. The laryngoscope's nice to have when you've got this upper airway obstruction. You just pull the jaw open and you look in there, and there's that block of food or whatever it is, or toy that could have been swallowed, or any other number of things. You just lift it right out, and you're a hero, and you fix the problem right there in 15, 20 seconds. Don't be afraid to do that. I mean, these people are in, they can't do it. You got to do something. There's no reason not to. Scalpel blade we talked about, ambu bag and pocket pads have to do with the breathing. Nitroglycerin you ought to have for the people that have the chest pain we talked about. It'll also relieve esophageal spasm from the acid. So just because they respond to it doesn't mean that it's hard. It also will lower blood pressure, so if they have a hypertensive state, you want to lower it, give them a nitro under the tongue. If one, you can give them up to 3, 5 minutes apart. Atropine, lidocaine, you probably don't need. They have to do more with arrhythmias. A defibrillator. You have a defibrillator? Great, because as soon as you identify the B-fib or the B-tac and you shock them, the sooner you shock them, the better. Before the paramedics get there, before you do an airway, before you do anything, once you identify one of those arrhythmias, shock them. And then shock them again and a third time, because the resistance goes down each time. Then go on to your airway, the breathing. But if you've got a defibrillator, use it. As soon as, if they don't have a pulse and they're not breathing, it's not going to hurt to use it. And you may shock them right back into a normal rhythm. They'll wake up 30 seconds later and say, what happened? Adrenaline for the asthma. For the urticarias, for the anaphylactic responses. Xanax, put that on there because it's extremely useful for the hyperventilators. Give them 0.5. Wait 30 to 60 minutes, and they'll say, I feel fine. Now, if it's pulmonary embolus or pneumonia or some other thing going on, they won't. They'll have a little bit of relief, but they'll still be complaining. They'll still have a tachycardia over 110. Take them to the hospital. So the Xanax is a good thing to use as a screening mechanism when you think they're just hyperventilating and their blood pressure's good, their color's good. You've got time to wait. Go on and give them 0.5 of Xanax. Use it a lot in the ER. Procardia is a calcium channel blocker. It'd be real good to have some 10 milligram tablets of Procardia around because it drops blood pressure in 5 to 10 minutes. Give it by mouth. If you've got somebody with a high blood pressure, give them a Procardia, 10 milligrams. Just by mouth. Works right away, brings it down real smooth. They don't get hypotensive. Okay. It's a nice thing to have. Especially if they're in this pulmonary edema where the high blood pressure is backing up the fluids into the lung. I would recommend that you have that. I've not run into any trouble giving it. I think if they have high blood pressure, if it's 220 over 120, give them a Procardia. And nobody's going to fault you for doing it. D50W, Narcan, thiamine have to do with overdoses, unconscious patients. Ipecac for the overdoses. There again, the sooner you get that in, the better. The only time you wouldn't is for corrosive material, Drano, gasoline, kerosene, where you don't want them to draw. Valium we talked about for seizures. That'd be mainly it. Ice you need to have around. Melting ice is what you want. You can put it directly on any body part except fingers and toes. It draws out the heat. That's what you want. It's not so cold when it's melting. It's only 32 degrees. Better than those chemical packs that you break, which can get too cold. Suction is great for people who have a lot of secretions, or even more if they've thrown up and they're sucking it in. Suction around it is really good. Benadryl we talked about for the dystonic reactions and for allergic reactions. I didn't mention nosebleeds. Let me mention that. Most nosebleeds are from the front of the nose and can be stopped with pressure on all the top part, just like you stop a cut on your hand. Lean forward so it doesn't run down the back, and do it for 5 minutes on the clock. If that doesn't stop it, do it for 10 minutes on the clock. If that doesn't work, bring them into the hospital. A posterior bleed is going to be profuse. It'll be running out, and it'll be running down the back, and it'll be coughing and stuff. People don't die from nosebleeds. If you've got time to get them into the hospital, if their blood pressure gets low enough, they quit bleeding. So it's kind of a self-limited thing. You do want to get them elevated, of course. You want to notice whether they're on anything like that. Observation. Any bleeding, of course, can almost always be stopped by direct pressure. You hardly, just figure you're not going to use tourniquets. They tend to be put on incorrectly so that they stop venous return, but not the artery going out, so it increases the bleeding. Better yet, just put direct pressure on. Even if you only slow it down, that's going to let the paramedics get there and do something. There are some pressure points you can use, but I wouldn't worry about that. Just figure direct pressure on almost every bleeding that you get. Skills, neck immobilization, you learned in CPR. Anybody that's fallen or unconscious, if you've got enough people there, somebody ought to be protecting their neck. Just put some pressure on it. You've got the collars on, put them on. Even if you're clearing their airway, try and keep some direct traction on the neck. If one person can take responsibility for that, that's wonderful. Airway access and protection we talked about. Breathing, circulation again. The physician has to do with putting their legs up if they're shocking. Observation is where you can just help tremendously when they come on into the ER. What color were they? Did they have a normal looking color? Were they purple? Were they clammy? Their skin dry, were they clammy? The rate and the rhythm of their pulse. Respiratory pattern, we talked about stridor versus wheezing. Neurostatus, are they moving everything? Can they talk to you? Do they know where they are? Is their neck stiff? Did they aspirate? This is, if they're having trouble breathing, choking, did they vomit? It's just nice to know. If you can, take a little piece of paper and look at your watch and see the times, especially in a seizure. If you can keep your head in a seizure or trouble breathing and say, all right, it's this time now, and the seizure stopped, at this time, that's really useful to know. You can't tell by thinking. You get an idea of it. 2 minutes can be 5 in a subjective sense. And the environment. Notice where they were. Were they in a closed room? Was there medicine around? Could they have fallen? Who else was around seeing what's going on? If you're all trained, and the observation can be the most important thing you're doing, ABC, airway, breathing, circulation, and add an O to it for observation. Once you've done those basic ABCs, take them and look around. Think, now what am I doing? In that book, House of God, they had 14 rules for interns. Number 7, I think, was in an emergency, take your own pulse first. I'm just saying, take time to think. You can be much more helpful than running around and yelling. Well, I hurried through that. It's just an overview. I hope I've given you a few hints. Liability. For the average bystander, if you're walking down the street, somebody collapses in front of you and is bleeding from a severed limb, or they're seizing, or anything, you have no legal duty whatsoever to do anything to help that person. you can watch someone drown 10 feet away from you, and you have no legal duty, except in certain circumstances. If you undertake to rescue that person, then you have a duty to continue. That rescuing may be as simple as telling someone else, I'll help, because then that other person is relying on you to do it, and he may go for help someone else. So if you tell anybody you're going to help, you ought to go ahead and do it. And working here, you have a legal duty to your patients. Okay? Being on this campus, if something should happen and you work here as an employee, you have a legal duty to help. So, on the other hand, you're going to be shielded from liability unless you are grossly negligent, even if you have a duty. An example of gross negligence would be a physician who sees someone fall from a heart attack or whatever and manipulates the head too much in trying to get an airway, and the patient winds up paralyzed. That physician is charged with the knowledge of knowing that you have to take care of them. Now, whether someone lesser than a physician would be charged with knowing that, or whether a psychiatrist would be charged with that, that's open to a jury. That's what you call an issue for the jury to decide. It's not a matter of law. It's very rare for a rescuer to be held liable in an emergency situation. Very, very rare. I would be held to a much higher standard than anyone in this room, because I do this for a living. That is taken into account. So don't be afraid to help. You're going to be shielded in almost all circumstances. The greater the urgency, the more shielding or immunity that you have. If someone is going to die in the next minute, you can try anything. You can put that scalpel in your hand and make an artificial airway open. You don't have to worry about their neck. If they get paralyzed because you attempted to clear their airway and they were going to die in another 30 seconds or 2 minutes or 3 minutes, you're not going to be liable for making them paralyzed. I didn't mean to give you the idea that you needed to worry about the neck paramount. The neck is still underneath the A, B, and C, lower than. It's nice if you think about it, but it's only someone with my skills that's going to be charged with thinking about it. Are there any questions about refusal treatment for people living wills? You know, the Supreme Court just had a case. Any more, these patients are going to have to make clear while they were competent that they don't want anything done. When I hit 45, I'm going to have tattooed on my chest, shot twice only. They can't get me back after twice, and let me go. And that would be clear. That's clear and convincing evidence, and that's the standard that you have to have. A living will is another.
When you get 45, you might want 3 times. One more shot.
I was going to say shot thrice only, but I thought that might confuse people too much. They'd be arguing about what thrice means. There's a more sophisticated audience.
My question doesn't is not pertinent exactly to your lecture, but it is pertinent to the living will because it is here. And I was wondering if somebody had a relative who is like a vegetable, and they say to the hospital, "Thank you very much, you did what well. I want him now home." Do they have the right to take it? And then, of course, they can more or less do what they think they want to. I'm surprised that 7 years they keep somebody there in that hospital, people who would like.
The short answer to that is it depends on what state you live in. If you live in Missouri, where the Cruzon case that just came down is, then no, you're not going to be able to do that. The family members or the doctors do not have the right to say this patient no longer deserves the right to live. New York, Minnesota, California are on the other end of the spectrum. They will accept it doesn't have to be very good evidence that that's what the patient would have wanted. What's controlling is what does the patient want? Now, if the patient can't tell you, then you're looking for evidence of what would they want if they were able to tell you. And in many cases, the relative, the spouse, or whoever is deemed to be in the best position to know the patient's wishes if they could tell you.
Yes, but I mean, if they want to take the patient home, not everybody is obliged to be in a hospital. And the
Yes.
family can say to the hospital, thank you very much, after 6 months you have done what you want, we want him home, without saying why or how. Huh?
If they are dependent upon services in the hospital that could not be provided at home, many hospitals would obtain a court order and would not let you do that.
Let's see.
Okay? If you have someone at home that's terminal, and they get into trouble and you think they're going to die, you ought to think twice about calling the ambulance. Because once you call them and they don't have that living will in front of them, the paramedics are legally obliged to perform CPR and do what they can. We get many people that come into the ER and we have to work on them hard, and then the family comes in and says, what did you do that for? Well, we had to. That's the answer. You want to have that living will, or even better, is a thing called a durable power of attorney for health care, where you designate someone specifically to make decisions for you in the event you're not able to make them. And that includes all decisions: life support, organ transplant, organ donation, even the right to food and water through IVs or infusions. And that holds up very well. And if anyone would like to see a copy or a copy of it later, I brought one with me. Sign these, get them signed by witnesses who have no interest in whether you live or die, and give copies to everyone, your lawyer, your spouse, your doctor. Don't put it in a safety deposit box. You can't get that out while you're waiting for the ambulance. Anyway, you've got to make it clear what you want while you're competent to make that decision. Now, you may think if you're only 25, that that's not very important, but that's what Nancy Cruzon was in Missouri. She had her trauma. Make it clear. If you don't know what you want done, give the responsibility to someone who you trust will do what you want. The living will doesn't do that. That's making your wishes express. This durable power of attorney does not take effect until you are incompetent. Okay? While you're competent, the other person has no say. But if you become incompetent, say, they take over. That's better than having a doctor or a state or a hospital administrator say what you want.
Do copies of this durable power of attorney have to be original signatures, or can they be duplicate signatures?
It can be a duplicate. Somewhere the original has to be. But make all the copies you want, because what they're looking for here is evidence. They're not looking for the document itself. It's evidence of what you wanted. And you might want to update it every 5 years. Write the new date and say, this still reflects my wishes and sign it. Have a witness sign it.
That doesn't have to be legalized in any way.
It does not have to be notarized. That, of course, makes it a little better. But I'd be glad to have them make copies of one brought. You need 2 witnesses to cover it pretty nicely. And they shouldn't be someone that will benefit by your will.
Is there an issue of having to be declared legally incompetent?
No, you don't have to go through a judicial process. It's the doctor can make that decision. We do that all the time with the emergency conditions and the involuntary.
You talked about the use of the defib as the first step. What are the liabilities, if any, of having a defib on the premises and not using it?
Depends on your skill level. What someone might expect of you. If you have never defibbed somebody and you haven't had CPR, then there's no liability, of course. If you've had CPR but it was 3 years ago and you haven't run into any case, there's no liability. If you've taken CPR and you ascertain there's no pulse and you're not breathing and you don't use it, you're probably still no liability, because nobody really expects a bystander or someone who's only at CPR to use it to do it.
What about a psychiatrist?
Psychiatrists should be trained in basic life support, and if they ascertain there's no pulse and there has not been, and the patient's unresponsive, that would be a jury issue. It really would. Why not use it? If you've got it, what have you got to lose? I'm saying it's harder to say why you didn't do something than it is to say why you did do something in a legal sense. The same thing with the Terrasant decisions where they have to warn third parties. It's a lot easier to explain why you did call the police or warn the third party than it is to explain why you didn't. Something adverse happens. You're better off erring on the side of action, I think. Even though the axiom for doctors is it's prima non nocere, first do no harm. But that's in non-emergent situations. I tell you, if somebody's going to die, do what you can, and nobody's going to second guess you. They may second guess you, but the courts won't second guess you. You're the one on the scene. No one has a better idea of what's going on than you do. You don't have anything to lose by defibbing them. If they've been pulseless for, somebody saw them collapse and they're pulseless and they're unresponsive, and you take it again and they're still pulseless, and you've done your airway. This is saying you don't have a monitor showing VFib or VPAC. Why not do it? Even if they are asystole, it's not going to hurt. And it may bring them right back.
Dr. Davis, I think the hidden question is, what's legally and professionally expected from a psychiatrist in the case of a medical emergency? Basic life support versus acute life support.
Basic life support. Any MD, anybody with MD after their name should know basic life support. No question about it. A lot of them don't. But if you're in the grocery store, even not on this campus, if people know you're a doctor and somebody collapses, they're going to wonder why you didn't know. Now, that's the ethical part. You don't really have a legal liability there in the grocery store. But you have an ethical, moral obligation. And you are protected by statute, American statute, regardless of the fact that you're a doctor. Here on campus, or on your facility, I think you would fully be expected to practice basic life support, but no more than that. If you do the defibrillation or if you do a cricothyroidotomy, that's beyond what you need. You're not required to do that. If you do it, on the other hand, nobody's going to fault you, even if the patient dies. I mean, that they died is proof that you needed to do it. Not that you needed to, but that you were justified in doing it.
What if you do it and there's damage afterwards and the patient dies?
Well, your answer there is they survived because of what I did. That's why a cricothyrotomy is not going to kill them. Defibrillation, if they're pulseless, is not going to kill them. And maybe who's going to say that it wasn't the thing to tell them? I think you would be applauded for your efforts. So they have trouble breathing, and you do a cricothyroidotomy, and then they start breathing. Who's to say what it was that let them do that? Maybe they coughed up what it was after you did the cricothyrotomy, and you didn't have to. But it's awfully hard for even another healthcare professional to criticize you or second guess you, let alone a judge or a jury who has no medical knowledge. I still say it's easier to explain why you did something than to explain why you didn't. But you don't have any legal duty as a psychiatrist to do a cricothyrotomy or to do a defibrillation. BLS is all you're going to be held to. Now, you might not even be held to BLS depending on the jury. There again, that would be a jury issue. There is nothing written down that I know of in terms of standards on that. But it seems to me that that would be where you would draw the line. MD should know BLS.
Any other questions? Thank you very much.
He didn't move. Yeah, all you can do is alternate between zooming in and zooming out, and so people will not change. That's about all you can do.
The AHA doesn't sanction